All right. Well, thanks so much for joining today's Define webinar. It truly is my pleasure to introduce Dr. Gaby Cordova Ramos, who's an assistant professor of pediatrics at Boston University and a neonatologist at Boston Medical Center and Beth Israel in Boston. Some of us may remember her very excellent talk that she gave at our Define Forum in fall 2024, so we're very lucky to have her back. Dr. Cordova Ramos is a nationally recognized leader in health equity whose research and quality improvement work have transformed how NICUs across the country approach communication, social needs, and language justice. So it truly is my pleasure to welcome her as she speaks today about equity for Spanish-speaking families in the NICU. Thanks so much for being here, Dr. Cordova.
Thank you so much for the invitation. Like you mentioned, we talked a little bit about this on the fall of last year. So if there's some overlap for those who were part of it, I apologize for that, but I did include a bunch of new stuff. So let's see. Am I in the right view? I have two screens, so it always gets messed up. Okay, perfect. All right, great.
Oh, wait, sorry. It is presenter
It is
now.
presenter. Okay, swap. There you go.
There we go. Perfect.
All right, perfect. So thank you so much for having me. I love this group because it's like a lot of great work comes from this group, and I actually my very first study that I always use in any language talk came from this group too. So it's actually pretty awesome to talk with you, and I hope there's a lot of conversation. I actually shared some of the tools that we presented in the fall with a bunch of people who reached out afterwards. So I have nothing to disclose. I do like to start the talks about language with a statement of positionality, because of course your perspective that you bring to anything you do, including work, has to do with your own kind of lived experience. And so I am originally from Lima, Peru. Um, I came to the US in 2015 to do my pediatric residency at Boston Children's Hospital. I graduated from medical school in Peru. I actually learned English in my 20s, kind of when I made the decision that I wanted to pursue residency in the States, which made it so that I could take tests quite well in English, but couldn't quite speak. So it was a little bit of a steep learning curve the first few months of residency. I came as a visa holder, became a green card person when I married my husband, and I just became a U.S. citizen in September of this year, just before the shutdown. So it's all good. A note of terms. This literature is evolving, and I'm sure it will continue to evolve. The term limited English proficiency is widely used, and I continue to use it in my talks because it continued to be the official term used by the U.S. Census Bureau. The definition of limited English proficiency is someone who speaks English less than very well by self-report, and all the statistics continue to be around LEP. But there's been a number of editorials and some good work from many people in the field trying to move away from the term limited English proficiency just because of the deficit framing of this term when employed for families. And so the recommended terms currently are preferred language other than English, which of course you can have a preference for example, in my house, I can have a preference for Spanish, but I still speak English, so that doesn't necessarily imply limited English proficiency. But it is a more family-centered term, so I'll use it a lot. And non-English language preference is kind of like the other side of the same coin. So I kind of tried to change my title this time, and I was just talking to a friend, and we just came up with this analogy, which is like really like language should be treated like a vital sign. The way we use a vital sign in the NICU is we measure it, we act on it, we intend to prevent harm. And we do this systematically and continuously. And I think language should be treated the same way. Identifying a family who has a preferred language other than English should trigger the same reliable, protocolized response with the ultimate goal of providing optimal care for everyone, but also reducing language-related care and outcomes disparities. Um, so just a little bit of numbers. This is as the U.S. Census Bureau from 2022. 1 in 5 people aged 5 and up in the U.S. speaks a language other than English at home. And 8% of those, representing 26 million people, speak English less than very well, meeting the definition of limited English proficiency. And 2/3 of those with limited English proficiency speak Spanish. So I know these talk was particularly focused on the Latino community and Spanish speaking families. But of course, this is going to be a growing number. Well, who knows with all the changes that are happening. Um, so there is just like everyone, I'm sure is aware around the mandates and regulation for equitable language care. But I'm just going to draw your attention to the class standards, which stands for culturally and linguistically appropriate services. So they were first um, released in the 2000 and updated in 2013, basically just making them more operational, but they are exactly the same. There are 15 standards and they are in three big buckets around governance, leadership at work for communication and language access, and engagement and continuous improvement and accountability. And out of the 15 standards, the ones that I think apply most for NICU families are these four around educating and training both leadership and workforce in these classes standards and practices on an ongoing basis, informing families of the availability of language assistance and offering these free of cost language assistance to anyone who needs them, and ensuring that those individuals that are providing language assistance are competent in doing so. So we were very interested in looking in kind of like doing a snapshot of NICUs, and we try to use our network to say, okay, what's happening? And we launched this national survey. We got 170 responses across level 2 and 4 NICUs across the 5 U.S. regions. And basically, what we learned is that the very basics, which is just documenting language and reliably using an interpreter of any modality, continues to be inconsistent. So 63% of those who responded reported consistently documenting caregivers' language over 75% of the time. And only 41% of those responding said that they consistently used in-person or remote interpretation more than 75% of the time. And of course, we know the NICU is so different day and nighttime, and the services available are so different than day and nighttime. So we were also interested in learning about the patterns of interpreter use by those type of shifts. And we were very kind of like surprised to see is that even during the daytime, when you mostly across systems, you now have access to in-person interpreters. The use of interpreter services is still under 30% per report. And up to 50% reported continued to rely sometimes on ad hoc interpreters, even during the daytime. And similarly, there was a good number that during nighttime and weekend times continued to say that sometimes we still use ad hoc interpretation. So we appreciated that people were so kind of like honest about it, but kind of like very interesting to see. And of course, remote modalities of interpretation continue to be some of the most used, but it still is kind of like around 50% for like consistently being used. And of course, not only is day and nighttime different in the NICU, it's also like all the various communication events are just so different in nature and in high yield of the communication that's being relayed. And so it's very interesting to see that people feel that high quality interpretation, which we define for them as in-person interpreter or certified bilingual staff, is most needed for things like family conferences and discharge teaching, where they reported almost always relying on this high quality interpretation, but very few reported almost always or even usually using these high quality interpretation modes for daily clinical rounds or regular bedside updates, which can be just as important. And we were actually really surprised to see that like people are like widely agreeing with the fact that frequency and quality of communication can be different for families with limited English proficiency compared to English proficient families. But they strongly disagree that the care is different, which is so interesting, right? If the frequency and the quality of communication is different, yes, the care is being different. But people kind of like refuse to believe that. They say families receive the same supports, and of course, infants receive the same care, which is so interesting. So overall, the takeaways of this is that like this is still kind of like an area where there's a lot of work to be done. It's the practice is highly variable, so QI is just kind of one of those perfect modalities to tackle this issue. And but also gives you a sense that like the NICU is like kind of this world of many different communication events happening throughout the day and across the hospitalization. So there is not like a one perfect thing to do, but it's possibly that different modes of interpretation just have distinct advantages and limitations that could be kind of like strategically used to optimally address those changing needs of the NICU context. So what did this mean for families? And I'm kind of preaching to the choir here for the next few slides, but like just stay with me. So of course this is work that came from your group or from Colorado. And I love it because it's so illustrative of how important this is. This group reported that Spanish-speaking parents are 4 times more likely to incorrectly identify their baby's diagnosis compared to English-speaking parents. But what's was also really shocking is like when you really look, these families were only receiving um, updates from both nurses and doctors in Spanish or using interpreters less than half of the time. So 39 to 45%. So that's crazy. And of course, it's not just kind of like how well you understand your baby's diagnosis, it's also kind of like how much parents are involved in essential activities of daily infant care. So this other group, which is I think is from Stanford, looked at differences in parental holding based on language. And they found that this huge developmental activity, which is skin to skin, which we all love, which has so many benefits for the diet, was substantially lower for families who speak a language other than English, even when adjusting for rates of parental presence. And we looked at kind of breastfeeding as one of these other essential activities that families in the NICU do as part of their caregiving. And we used a cohort of our state, our kind of penguin, which is our state collaborative, and we looked at time to discontinuation of mother's milk provision. And you can see here in blue, non-English, English-speaking non-Hispanic white families, and in green, Hispanic families, with the dotted green being non-English Hispanic families, most of them Spanish, just a couple of Portuguese. But basically, you can see that Spanish-speaking Latina moms just have the earliest drop in breastfeeding um, discontinuation. And we also were interested in kind of like understanding the nuances of the family experience. This was very recently published with Nikita Kaluri as a first author. And I just love this paper because it's just so illustrative of the experience of a family who has limited English proficiency in the NICU. And we used cohorts across 2 states, including Colorado. Oh, sorry for that. So basically, we find a number of themes across the sociological model, the levels of the sociological model, and within the individual level, families talked a lot about the stress caused by having unaddressed language barriers, and I'll show you a quote in the next slides. They also talked about kind of like the varied levels of empowerment that they have to advocate for the language needs, and somewhat how they justified suboptimal interpreter use. So one mom said, just the lack of information ends up creating monsters within you. So, you don't have enough information. You end up being more worried about simple things just because you don't know. And families also talked about um, kind of like not wanting to bother the teen. Like when they would turn off the screen, maybe something popped in my head. I didn't want to bother them. I told the nurse to tell the nurse to turn it on again. So I had to live with that question unanswered. And many families just said, like, they just can't be with me all the time. Sometimes I didn't want to ask for a translator because I knew they also had to care for other babies. They couldn't be with me all the time. I tried to ask things only when it was really necessary. So in terms of the interpersonal level, so that kind of like communication between staff and families, many families use the word bendecido, which means blessing, of having language concordance. Um, and they also talked, and almost universally, about those small, non-interpreted, informal interactions and their value in building rapport, but also kind of gave some experiences of differential treatment based on language. So this is a quote about this blessing of the language concordance. I was blessed to have 2 nurses who spoke a lot of Spanish. One of the lactation nurses spoke Spanish. I love that. And this value of the building rapport through non-formal interactions was actually really interesting. Many families talked about Google Translate or like broken kind of Spanish as something really valuable and kind of like really, really well received when it was used for kind of social purposes. So the nurse always chit-chatted with me with Google Translate. It was so sweet. We laughed a lot. I taught her a few words. Or some of them spoke very little, but it was always very nice because they were kind and you could see they cared and they were trying to communicate even if it wasn't perfect. And differential treatment based on language. We also sadly had many instances in which families talked about kind of like the feeling of isolation that stems from not being able to communicate naturally. So sometimes I saw that mothers who speak English to get to ask more questions to the nurses and they just get to talk more with the nurses. And in terms of institutional level, we found differences in the quality of interpreter services, just general systemic barriers to timely access to language services, and the utility of audiovisual aids. So for the quality of interpreter services, it was clear that people like had different experiences with interpreters who were really good and others who weren't as good in verifying that families understood what was being communicated. In terms of systemic barriers, families talked about the access, and the time that it took to get access to language services. And in terms of multilingual aids, just families talked about the value of things like videos or handouts and things like that. So this family said that not speaking English didn't affect her because they had a lot of these things shown in videos that were in Spanish and that were very clear. So many recommendations also came from these, in the sense that at the individual level, there's a need to identify families' individual communication needs, both on admission and potentially throughout. Um, Inform families of their right to receive language services. Obviously, strive for language concordance, which will take like time through hiring and retention practices, but also fostering culturally sensitive care practices with the staff that you currently have, and leveraging those very small informal interactions to build rapport. And of course, at the institutional level, continue to improve the interpreter quality, access, and use, and standardizing those best practices for various clinical touchpoints. And beyond the family experience, there's also evidence about the impact of unaddressed language barriers on safety and discharge readiness. So more and more we know that compared to English-speaking families, those with preferred languages other than English feel less prepared for some element of discharge, have higher emergency room and utilization and readmissions after discharge, are more likely to experience preventable errors after discharge, and have lower awareness of some essential services such as early intervention programs, um, which are so important for NICU grads. So in general, like kind of like I went a little bit fast because I do feel that this is preaching to the choir, but that caregivers with preferred language other than English have a number of communication and engagement barriers at multiple levels, and families over and over again report experiencing isolation, delayed or missed opportunities to be involved in infant care, and less social and emotional support when language barriers are not properly addressed. But the other takeaway is that just language ability and comfort is contextual. I may be very appreciative and happy of people hacking their way through saying hi and showing me a picture. But I also may be equally appreciative of high quality interpretation when an important medical update is being provided. So I do want to spend some more like a slow down and spend some more time in two quality improvement initiatives, one from Stanford and one from our own unit, that use a lot of these findings into trying to translate them into equity-focused QI to advance language justice. So the first one comes from the Stanford group, and they did a very interesting bundle of interventions to increase the number of families with a preferred language of Spanish who received a daily medical update in their language by a relative 50% from baseline over a year. So this is a massive unit. This is a 72-bed unit, level 4 in California, and they had about 30% of Spanish-speaking families. So of course, they started with identifying the potential causes for family not receiving updates in their preferred language. and looked at things from the interpreter side, their staff, their availability, from families, their ability to be at bedside and their awareness of interpreter availability, from the processes of people to know how to request an interpreter and how to use it, from the provider perspective, knowing about the need, feeling like they don't have the time to request one, not trusting that they would do a good job, not thinking that it's needed, um, etc. And of course, things related to the hospital themselves, like lack of education, limited funding. And they focus their change ideas primarily on three buckets. So one of them is staff education regarding the need for language services, the best practices, and processes for using interpreters. The second bucket, empowering families to request interpretation when needed. And the third one, just removing barriers to interpreter utilization. And staff education was fairly simple, but per their perspective, one of the most important things they developed these 30 minutes educational sessions, which were targeted to all different types of providers. So there were some videos for nurses, some videos for doctors, some videos for residents, and they were delivered to these different types of providers in their different types of meetings. And they also modified kind of their huddle forms and their handoff tools and their progress notes to include language preference in an interpreter use. And they kind of standardized for their group. Like that was like the clear message for their education was who should use an interpreter, when should interpreters be used, and what modality of interpretation should you use. And that made it kind of like very clear for everyone. In their second bucket, in terms of empowering families to request interpretation, they just did this very simple double-sided bilingual interpreter request card. So that was delivered to their families on admission by a patient navigator. So these cards were an opportunity to remind families, I'm giving you this card because you have the right to interpretation. So it was kind of like giving a little bit of permission to request an interpreter. And in their third big bucket for removing barriers to interpreter use, they focused on stationing an interpreter in person in the NICU for 2 hours each day and developed a system whereby this interpreter could float across their 4 teams in their base, so that they wouldn't just be sitting there not doing anything, and they would just serve the different families at different times. And they also launched this like pilot program for nighttime family center interpreter rounds, understanding that a lot of Spanish speaking families could only visit at nighttime. And so even standardizing that during the day may not reach these families. So the results were not surprisingly awesome. So they went from a baseline rate of in-person interpreter requests for a Spanish-speaking person day of 0.2 to a steadily increasing all the way to 1 request per Spanish-speaking person day by the end of their project period. And you can see that there was an increase in these interpreter requests after each one of their interventions. And they also monitored the use of all other modalities of interpretation, because prior to this work, they also relied a lot on video interpretation. And so they very importantly saw that interpretation in general increased, both for in-person interpretation and for remote interpretation. So the takeaways of this work were that these things are fairly simple to do, like other than like the cards are pretty simple to do, educating is pretty simple to do, potentially stationing someone in your unit takes a lot of talks, but it's not impossible, especially in a large academic center. So these are relatively low cost, relatively low effort interventions, and they all had a substantial response in NICU utilization of interpreter services, both in person and across all modalities. In their own view, they feel that the type of education they did really primed their staff to welcome all the subsequent interventions. And the way they sequenced it too is they had everyone educated, then they had families kind of like educated at the same time, and then they made it easier to do by having someone stationed there. And by having someone stationed in the NICU, they feel they had this profound impact on unit culture change regarding language access, because if they're going through the hoops of having someone on site, it must be important, right? So it was kind of like a combination of how each one of these changes like had some synergy with each other to make it work. And all these things are fairly sustainable. Once you can make the case that the interpreter in the NICU for 2 hours is high yield and very helpful, then you can make the argument that all of that can be sustained. So really love this QI work. And the second one, which I did share past fall, um, we focused on the next level, which is a little bit harder to measure, I'll be honest, because they measured interpreter request through just electronic medical record pool, because they request their interpreters through their electronic medical record. But we wanted to kind of focus on the quality of the communication from the family perspective. So we set out to increase the percent of families who receive effective and appropriate communication during their infant's hospitalization by 20% from baseline by the end of a year-long period. And we also set out from the start to decrease inequities in communication by language preference that were detected during the baseline period. So our driver diagram looked similar. We were interested in things that were driving suboptimal communication between the staff and families in the NICU, which we did for everyone. Like the fact that some of the concepts are complex, the fact that caregivers are stressed, that a staff is busy, that many families, especially in our safety net setting, have low health literacy, and the fact that for families that don't speak English, there was inconsistent interpreter use. We also had this very important communication event, which is the first family conference, which was not standardized in our unit. So we focused on that as a key kind of moment for us to measure these things. And we wanted to standardize the timing of it and make it happen. And ultimately, we focused also a lot on interpreter utilization, but more as a process measure. So in our first PDSA, we basically created these very simple laminated bedside cards that were placed on baby's bedside on admission, just along with their name and their weight and all those things. And a form that was given to families prior to their first family meeting and after they had their family meeting. And all these forms were available in our 3 most common languages, which are English, Spanish, and Haitian Creole. We do have many other languages, but this was just for the purposes of the project. This is what the family laminated bedside card looks like. It's very simple, but it kind of reminds people that there needs to be a family meeting, so it puts just write down the date here. It also has the best contact number for families and some QR codes for families to access things like a NICU dictionary, which we ended up eliminating because no one looked at it. Timelines for babies born under 34 weeks and over 34 weeks, just for big milestones. When are babies supposed to start eating? When are babies supposed to get vaccines and things like that? Information to give families and friends about how to be helpful. And I think the thing that qualitatively families appreciated the most were these welcome videos. And I'm kicking myself that I didn't include a video here, but it's basically a very short video from a parent to a parent, basically giving the message: the NICU hospitalization can be hard, but you're not alone. You can ask, and empowering families to ask questions as needed, inviting them to participate on rounds if desired, and asking them to request an interpreter to not hold back if needed. Let's see. Oh, sorry. Thank you, Dr. DeCamp. I've loved a lot of your work too. Then this is what the family communication form looks like. It was co-developed with families, and we implemented it across Boston Medical and Beth Israel, so 2 hospitals. And it was a very simple form that was intended to just kind of remind parents that the goal of this one important event is to explain to them the care that the baby's getting, the things that are coming up next, answer any questions. So it focused on understanding their support systems, understanding how they like to receive information, and explaining a little bit about what's coming. And the back of it, and this was completely a family suggestion, and I think it was brilliant. It was just very simply. Sometimes you ask, "Do you have any questions?" And people are just blank, and it's understandable. There's so much going on, and so we had parents say, sometimes you ask me and I have no clue. And then, like, when I process things, I have all these questions. And so they came up with this list of things that they wish they had asked when they were asked, do you have any questions? And so some of them were related to the big picture, some of them were related to the team, some of them were related to keeping track of information. And of course, we added the going home just because of a process of identifying families who could transfer closer to home. And then we are a teaching hospital, so we have a lot of residents in our unit, and they lead a lot of the conversations with families. So we focused on training our residents, more so like we did general education of all providers, but we generally trained, just had a session of training residents. And this rich curriculum was co-developed with the residency, and it was basically trying to address both linguistic and cultural needs of families in the NICU. And one of the emphasis was on the teach back technique. So especially after events like a family meeting where there's a lot of information relayed, saying things like, I've just said a lot of things to make sure I did a good job and explain things clearly. Can you describe to me? And just verifying that there was understanding of what was communicated. At the same time, as part of the second cycle, we wanted residents to document every time they had given an update to a family and whether an interpreter had been used. We weren't necessarily measuring these to track it. We wanted to use it as a means of accountability. So they thought we were measuring it, and it would be kind of like a reminder of, like, I did it. And as part of our third cycle, we focused on these multilingual written and audiovisual aids. So a lot of the things a lot of the times we try to explain concepts that are kind of hard to understand. So we developed this little flip chart. It's not so little, it's kind of like this size. And it just flips with different pictures. So you can see things like intestines, to be able to talk about the inflammation of neck and the risk of perforation and things like that. Or you could see lungs and just talk about RDS and talk about intubation. And so we have some for intraventricular hemorrhage. We have another picture for eye exams. And so all these concepts that are a little bit abstract had some pictures to help with the communication. And then we also developed these one pagers for the 10 most common NICU diagnoses and made it available in English, Spanish, and Haitian Creole. So this is an example of respiratory distress syndrome, what it is, what causes it, how common it is, and what treatment will my baby get. And all of them ended with, like, talk to your team. They are here to help you, like, ask questions. Like, all of them were like constant reminder of please ask. And then this was one of my favorite parts of the whole thing, which was we got some funding from the AAP to develop some discharge videos, and this was all parent led. So parents came up with the topics they felt were the most high yield, with the content of each one of these contents, and they basically developed the script themselves. And they were very short, 4 to 5 minutes, and they talked about things like what to expect after NICU discharge, and things like that. And we made them only in English and in Spanish, but there's some ongoing work trying to get them into Haitian Creole. And they are available in the AAP website, so that's the link if you want to check them out. As part of cycle 4, we used some of kind of like this initial work to try to make the case for improving our ability to have better language services. We had phone interpreters at the time. So we convinced the leadership to purchase an iPad. And even though the video piece of it is still not great, the quality of the audio is wonderful. And just the portability of it is excellent. And so families really, really loved it. And the second big piece that we heard from families is like calling to the NICU is one of those things that is the hardest for non-English speaking families. So it's not just when you are in the NICU, but it's like when you're trying to call in to check in, because whoever picks up the phone doesn't necessarily speak your language. And so we had these little laminated cards across all the unit phones so that when families call, an interpreter could be conferenced in. And it gets conferenced in really quickly. There's very little lag time. And nurses really appreciated that. And so this is how we measured communication. So this is absolutely not validated. This was just our kind of makeshift way of trying to get families' perspective on how well the communication went. So what we make sure is that families understood that they were given this form after they had their family meeting, and it was put in a sealed envelope. And it was researcher staff who got it back and said, your medical team will never see these responses. And we used it for measuring these two things. So quality of communication was defined as responding agree or strongly agree to all of these statements. So I was asked about my concerns about my baby. I was asked about my goals for my baby. I was able to ask all the questions I had. The team explained the ways in which I can participate in my baby's care, and the team was respectful and sensitive to my customs and values. And effectiveness was completely borrowed from the work that was done in Colorado a few years ago, in terms of matching what the parents say is the reason the baby is in the hospital to what the providers think is the reason the baby is in the hospital. And this was measured at the first family meeting, understanding that babies can have many other things happening later on in the hospitalization, but kind of like the main diagnosis. And so the research team would like collect these forms, give it to the resident, and ask the resident to write in the back of it what the actual diagnosis of the babies were, and then someone will corroborate the concordance. And in the back of it, we had some measures only for families who spoke a language other than English that had to do with like, was an interpreter used in your family meeting and what kind of interpreter was used? Was an interpreter used for clinical rounds, where if they participated on clinical rounds? And in the past 3 days, how did you get most of your updates from doctors and nurses? And a last question about how comfortable do you feel to ask for an interpreter? So in terms of results, so at baseline, we did find a difference in families who agreed or strongly agreed with high quality as defined by this survey. So 79% of non-English speaking families, as compared to 86% of English speaking families, had agreed or strongly agreed to all those questions about how well the communication went. But throughout the project period, this rapidly increased to like nearly 100% of families saying that all of those things had been addressed. And in terms of correct infant diagnosis, about half of non-English speaking families at baseline and about 69% of English speaking families at baseline had a correct infant diagnosis. And this increased to 81 or 87% respectively during the project period. And in terms of standardizing the time to first family meeting, at baseline, we were having family meetings past a week for both groups and nearly 2 weeks for non-English speaking families. And at the end of the project period, this was reduced to about a week for both. So the takeaways of this work was there like these also relatively easy interventions increased parent-reported measures of quality of communication and understanding of the baby's diagnosis. But the important thing that we feel is so key of this one is that all these interventions improved communication for everyone. But it just also particularly helped families with limited English proficiency. So it was a good example of kind of how QI can raise the bar for all, but also reduce disparities at the same time. And I always want to make a plug about language barriers not being just language barriers, because there, especially in the US, families with preferred language other than English very often have many other forms of socioeconomic disadvantage. So this is looking at National Survey of Children's Health from a few years back. But you can see the gradient. So you see Latino families who speak Spanish in dark blue, Latino families who speak English in the light blue, and white families who speak English in the lightest blue. And you can see that the Latino families who speak Spanish are that much more likely to not have completed high school, to have an income below the 200% federal poverty level, and to report in the previous year having had issues with insurance or insurance gaps. And in a pretty steep gradient as well. So I loved to read that Stanford work and see, okay, they thought about this. They thought about a lot of these families not being able to be in rounds at the bedside. And they thought about how to address that need at nighttime. And that's, I think, how you do equity focused QI. You think beyond, okay, we're going to make everyone use interpreters and we're going to educate them all. And you kind of try to break those systemic barriers to the extent possible and what your funding allows. So just to close it out, I do want to remind you all, and you know this very well, how language is it's so fundamental to the human ability to construct meaning, to understand things, but also to convey meaning and to interact with others. So in the NICU, it also serves to articulate what you need and what you prefer. And all of that is just so essential for your NICU experience as a whole. And language services are not meant to just be a tool for families. They are definitely also a tool for those of us who lack the skill in those non-English languages to efficiently care for a linguistically diverse patient population. So language is definitely a vital sign because we can systematically measure it, we can activate on it reliably, and we can track outcomes related to safety, family experience, and care practices based on it. And all of this QI work, which was highly successful across these various different NICUs, was very kind of like a small, low effort, low cost, just organizing things and reminding people to use the structures that are in place. But of course, system level changes are more likely to unlock bigger gains. So that's it. QI is this like very powerful tool to advance language equity in the NICU. So I think these are just two examples of how people have done this in their own context. And none of this would be possible without an enormous amount of help from parents. So all these people highlighted in bold are really parent champions who didn't just attend one meeting. They were part of the QI team. They were compensated as members of the QI team at $100 an hour, which is not optimal, but it is a consultant level pay. And they had voice in absolutely everything from what was measured to the tools that were used to how it was shared with other families. And I'll take questions. That's my little bilingual toddler.
Great. Thanks so much, Gabby. That is such a great talk. And every time I hear about your work, I'm so inspired to make changes in our unit based on what you have, all the great work you have done. We can open it up for questions, and I'm happy to get us started. So one question I did have, so you mentioned your work looking at how preferred language is consistently documented in the medical record. And I'm just wondering if you have any sort of strategies or ways we can make our EMR smarter when we have parents who have two different preferred languages. I feel like the baby often defaults to the birthing parent, but that isn't always what the other parent speaks. And I'm just wondering if you know how we can make that information better available to team members or how we can better communicate with both caregivers.
That is such a good question. And it's absolutely vital to this. And it's giving me an idea that we should modify that bedside card and have kind of both caregivers' language needs listed. I do think we try to default to the parent that has the language needs. So if both are in the room, we still use an interpreter, and that's how the education has been done in our unit. But I guess the one way of doing it is because the hospital won't do it, because it is the birthing person listed in Epic, doing it as part of our admission process, which could be in the form of something like some flow sheet in Epic that the nurses fill out the same way they fill out all the other admission stuff, or in things like our bedside card, which lists kind of the caregiver's best contact, family meeting, language need. So that could be actually done for caregiver one and for caregiver two, when that's the case. So any way in which it's reminded to the team that that's a thing. So either through Epic or in a bedside reminder, I think that's a way to start.
Thank you.
Thanks, Gabby. This was so interesting and great to hear updates on how this work is going. I also am always inspired by your work for our NICU here at Denver Health. Um, when you talk about language as a vital sign, I love how you describe that. And I've had a project in mind, and I'm just wondering if you know if anything similar has been done. In the NICU, our nursing staffing is often acuity based, and I'm wondering if you're familiar with any studies of actually accounting for language concordance as a marker of essentially a more complex patient. And if what I'm envisioning is a program where we would like try and get some funding to actually increase nursing staffing and decrease ratios in cases where there's a lack of language concordance or anticipated need for consistent interpretation and services. And for us, at least, Spanish is one thing. We have a fair number of nurses and the majority of our neonatologists, fortunately, who are qualified bilingual speakers in Spanish. But when we have a patient with a relatively more rare language, or even just something like Amharic or something, it can take longer. And as you know, the phone interpreters, as you mentioned, can vary a lot in quality. So I'm wondering if you have thoughts, since you have obviously been successful in getting funding for some of these projects, and where you would start if you wanted to design a study of increasing acuity-based nursing staffing to account for language disparities.
That is so cool, and we should meet separately.
Okay,
Um,
that'd be great.
we have currently a March of Dimes grant,
Mm,
where we're tying language concordance data collection to an ongoing trial. So what we're doing, the way we're doing it is we have each nurse has an ID, and each nurse completes an anonymous survey of their demographics. And so then we are measuring how continuity of nursing, so regardless of language or race, and language concordance between baby and nurse affect things like holding, um, presence, breastfeeding support, like self-reported kind of things. So,
mhm.
so a way in which we're measuring is shift level, because you have so many different nurses caring for
Yeah.
everything, so we're trying to see any differences in outcomes focused on presence, skin to skin, and breastfeeding by continuity or concordance.
Okay.
So it's one way of measuring it. It's just so messy in the NICU because you have so many different types of provider caring for the family. So when you
Mhm.
say language concordance, like the baby can have over 7 days, seven different people, actually
Yeah.
14 different people theoretically. And so depending on what the staff looks like, it could just be really hard to do. And so
Mhm.
we're doing that like shift level matching to see if we can kind of like truly study that. Um,
That's interesting. Yeah, that's a cool approach. I guess what I'm thinking about is trying to come up with a numeric way to quantify the additional time and resources that we know are needed to make sure that a family that's non-English or non-English, non-Spanish speaking gets the same level of care and communication that an English speaking family
yeah,
does, and then accounting for that in staffing. So yeah, I'd love to talk to you about it later.
yeah. I guess I wonder AI is another way
Yeah,
to try to like kind of like think creatively and may open up funding opportunities, for AI.
that's true. That's a good idea.
So we'll see. Some people at BI are doing some also really cool work with AI using it to read the progress note. So a HIPAA-based AI reading the progress note and translating it at the bottom into a very understandable kind of summary of what's going on. It's still at the very early stages of feasibility and acceptability and making sure it's correct and all of that stuff. But it's also kind of like a very cool use of it.
Yeah, that's great. That's smart.
Hi, Dr. Cordova. I had a question. I saw in one of the slides it said that like a large percentage of like Spanish speaking families had like a high school diploma or less. I was wondering if like parents are at any point asked if they need help like reading materials while they're in the NICU.
That's a great question. I think the general like recommendation in terms of health literacy is to have universal precautions. So regardless of so everything in the NICU for any parent, regardless of their degree of education, should be at a low health literacy level. Some units do a good job of screening for health literacy needs. So they specifically have like ways of asking. We don't. We just assume that everyone needs everything explained at the most basic level, and that's why we also develop these videos and visuals because some of our families like learn understand better that way, and a lot of our families, highly educated families, still appreciate kind of like videos and simplified information and images to process complex medical things that they may have no previous knowledge of. So we offer like the short answer is universal precautions for absolutely everyone to have these in a low health literacy level.
Thank you.
Hey, I'm Jasmine. I had a question about, I'm wondering if this has been done or if you've looked into this, but if there has been a change with these interventions of like the postnatal care. So after they get discharged from the NICU, if there have been like um just more follow up with like postnatal care on the family side. So like them going to clinic visits more or reaching out with more questions. And if you guys have looked into that, um yeah, just interested to know, just because I also come from a family that's Spanish speaking only. And for instance, like my mom, I'm talking about adults here, but um, my mom saw an increase, just like more connection with Spanish speaking providers, and that caused her, like after her surgery, to ask more questions and be more involved in her care. So I'm wondering if you guys have noticed something similar with parents in the NICU.
That is so cool. And there is definitely not from us, but there is definitely some work looking at discharge transitions, discharge so from NICU to post acute care. And they have seen a reduction in preventable errors from interventions tied to interpreter use, like more kind of like not exclusively like targeting language barriers, but kind of like including it in the bundle of things they did in the NICU. And they have seen like less errors and less admissions. I don't know if anyone has actually followed to see if people are just more engaged in their care out of their like experience of like having had a better NICU experience. I'm sure that's true. Like it's easy to hypothesize that. It would be interesting to follow our families to see how that changed their experience. But no, I haven't come across I specifically around if you kind of like had good language concordant care and like high quality interpretation use, how does that change your view of healthcare, like in your immediate post hospitalization like care? I'm sure it does.
Yeah, thank you.
Great. Well, thank you so much, Gabby. We really appreciate your time and expertise, and I'm sure we will be following up with you with more ideas and leaning on that expertise further. So really appreciate your time.
Thank you so much. You guys have my email, so I've shared a lot of these tools with a lot of people. So always happy to.
We
Um,
appreciate
to
it. Thank you so much. Hope
Thank
everyone
you.
has a great rest of your day. Thanks so much for
Thank you,
joining.
everyone. Have a great afternoon.